Ever got to use the little pointer? Okay, I want to use it today. This is what I've always said I need it because I'll point and you don't know where I'm pointing to, but we probably won't need it. Okay, so thoracic anesthesia. Last week's lecture was also thoracic anesthesia, but I pulled out some of that information just to be able to make this lecture all about one lung ventilation related anesthesia. But there are cases with anterior masses, mediastinal masses, where you're doing one lung ventilation, right? So a lot of cases we'll do it, but I tried to break them up. There's a lot of material obviously last week, and so we try and make it a little easier and more clear. So why do we need to do one lung? What's the whole point of this? Well, most of the time what we do is to help surgeons, help to facilitate surgeons. Like we don't have to muscle relax patients. We really don't. It does make it a little more convenient to put the breathing tube in someone that has paralyzed cords, right? Has anyone here ever tried to intubate someone and the cords are closed? What do you think the reason for that is? You didn't wait long enough for the muscle relaxant to work, right? Because this is magical, like we teach all this stuff and we go to practice and like they don't do anything that they tell us in class. Like, should we be ashamed of ourselves or not? Like, no, we know what's best practice, but we don't. And I'm guilty of it. You know, I'll have some of you with me and you guys could be like, yeah, he doesn't do that. But I also try and be academic too. So for instance, if it comes to like intubating a patient, the best intubating conditions are paralyzing them, giving medicines so they don't remember things that induce them, right? The analgesia, amnesia thing. But how do you know when they're ready? And what you really should do is put a train of 4, typically over the orbicularis oculi. Is probably more consistent with vocal cord paralysis. It's a lot harder to paralyze your diaphragm. Or you could put it on your ulnar nerve, right? Which is what muscle? Pollis, right? Adduction of the thumb here. Ulnar nerve is where you're innervating that motor. You could put it there and you could say, well, I want to see what the baseline train of 4 is so I know that they're fully, that I can subjectively assess if they're fully reversed. We really don't really know because, you know, you're just looking at this and you can say, well, you know, I mean, 4 hours later, you remember what the thumb did? Probably not, but it's sometimes helpful. So you put the train of 4 on. Some of the train of 4s have a constant twitch, like every couple seconds, it's just going to twitch, twitch, twitch. And what do you think happens with non-depolarizing agents? Twitch, 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 right? You start to lose that amplitude and that like thumb adduction. You have what's called fade. You sometimes lose all your twitches depending on how much you're muscle relaxing. So where I'm going with that is that we do certain things to help make other people's lives easier. Sometimes it's ours. So in this case, there's a lot of times where we're going to be doing one lung ventilation to make the life of the surgeon easier. Other times we have to do it to keep the patient safe. And we're keeping them safe because they could possibly bleed. And we want to be able to isolate that lung from the other lung. They could have something like an infection. If you're putting fluids or you're manipulating one side of the lung and you don't want to infect or cause stuff to switch over to the other side of the lung, well, you can isolate, right? You can block it off. And when we think of double lumen tubes, what we're really talking about is we're putting in a tube that goes through the trachea, goes down. We'll try and draw an accurate picture. Make note of the degree angles of the right and left. So we're left, this is the patient's right, this is the trachea, this is the left bronchus, main bronchus, this is the right main bronchus. We put a tube in, typically, that can isolate and the tube doesn't, it's one circle, but just for demonstration purposes, I'm going to show you that there's like a little port that's like right here. Just like a normal tracheal tube would have been right here, there's a port so that you can ventilate through the right side or you can ventilate directly through the left side. How do we isolate a lung? I mean, what do you think the most obvious answer would be? How do we isolate the trachea from gastric contents being aspirated into the trachea? What do? You throw it and blow up the cuff, right? So we'll say This dotted line is your vocal cords. Does the cuff go below or above the vocal cords? Goes below, right? So there's always a chance that there could be something on top of that cuff when you deflate the cuff, which makes you wonder how you should deflate the cuff at the end of the case, right? Here's your balloon. And we just said we inflate the cuff. So how many centimeters? 15 to 20? Yeah, good. What kind of device measures that? Sigmometer? So you can have one. I've seen some CRNAs have their own. They're terribly expensive for what they are, so I refuse to buy one. I'm trying to think of a way to be able to take a blood pressure cuff, I guess thermometer or whatever, and somehow outfit that to do the cuff pressures, because those are only $20. But as soon as you turn into a handheld one that can release the air, in one hand, it's basically you squeeze it, it's got a little dial on top, and you can release the air. It's like $150. Yeah, so we technically go pediatrics. I'm trying to relate everything to you guys so we can kind of all get this whole clinical thing. Pediatrics, actually anything, we really never have a spirometer. They're never seen a room, but in pediatrics, we're more concerned about overinflation of the cuff, which is going to be a big topic with thoracic anesthesia, especially when we come down to this cuff. And we know that this is, first of all, is this a left or right double lumen tube? Easy answer. It's a left, because it's in the left main ruckus. That's it. This tube's designed to go left. This cuff is even more important for damage to ischemic damage to the surrounding tissue. So thermometer and pressures are also important. One way that we sort of guess what the pressures are, or we tolerate whatever the pressures are, is that you can put your tube in, confirm that you're in, that's the most important thing. Bag, 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 bag. You blow off all the CO2 that would have been in the stomach. If you went to the stomach and you goosed it, there could be CO2 in there because you were ventilating them before and you were blowing CO2 out into their stomach. But if you ventilate them a bunch of times quickly, if there was CO2 in the stomach and you see it on your capnography, it goes away. Then you're like, okay, I'm really not in the lungs. You're also feeling that the bag has no compliance. But say you're in the lungs. So now you can kind of rest easy, right? You got the tube in the right spot and you're able to ventilate them. You put on a little bit of gas, you throw them over on the circuit, and now you can get ready to tape your tube, right? If you're happy. Listen to breath sounds on both sides. Before you tape your tube, and maybe this is better, listen to breath sounds on both sides. The person who's listening should then go and listen over the cricothyroid membrane. And then before you tape your tube, because I guess if you were left or right and you were kind of MAINSTEM, you would have been able to correct this. So at the same time, what you're now listening for is how much pressure to add to the cuff. And what you would do is you would turn the APL valve to about 20 centimeters, and you would hold the bag at about 20 because you turn the APL and you slightly close it to 20, but you're really looking at the little dial that tells you what your pressures are. So 10, 20, 30. And so you would want to inflate your bag by closing the pop off and having enough flows to get that needle to about 20. And then at 20 is when you should hear your cuff leak go away. So you inflate enough air so that at 20, the cuff leak that you're hearing with your stethoscope is gone. And that's a really nice trick to do in pediatrics who have a high risk with smaller airways. And the fact that even a little bit of edema on a small airway can cause a significant problem for them versus the adult airways. But it's good for general practice. Okay, so this is what we're talking about. So this is how we isolate. If there's bad here, it's blocked from going, and this is the left, it's blocked from going from here to here because this cuff is in the way. Now it can go through that tube, but the thing is though, is if you were to look at the tube, there's two sort of D-shaped lumens in the double lumen tube. So they kind of look like this. And basically, if I'm looking down at the patient with the breathing tube and stuff, and this is the left lumen double tube, this would be your left, and this would be your right lumen, okay? And so, as I'm looking down that's what this cross-sagittal view is. It's sort of like a D. You see it's like a D on both sides, which is opposite facing and stuff. So it's one tube with two lumens in it. So the bad stuff could come out of the tube to the atmosphere, right? It could come out to like where your workspace is, but it's not going to go into here. And now, if you're ventilating, because then each side has it's connected to its own port, right? So this is like one port with your kind of like cone thing on here that can fit, and this is your other one. So you can choose to only send your circuit. So left side, we're going to have nothing to the left side. Here's your circuit going to your vent. We're only ventilating one side. So there's some relative indications for one lung ventilation, which is telling you that it makes sense to do the double lumen tube or to isolate the lungs, but you don't necessarily have to. So if someone wants you to isolate the lung, but the patient has a lot of comorbidities, they're making you nervous to say, I don't think this is a good idea to go to one lung ventilation in this patient, or I'm worried because of a significant history of radiation or something that makes you think putting in a double lumen tube, because it's a big tube, could cause trauma, could cause more problems, right? We certainly, not everything goes according to plan. So ideally you could put a double lumen tube in, you can have more control, but at the same time though, what if you lacerate the carina when you place the tube? These kind of things, these decisions are made with the surgical team, hopefully before you bring the patient back. So you're all on the same page on what the needs are. You're bringing up your concerns for what the risk factors are for this patient from an anesthetic perspective, and the surgeons bring up their concerns for how they're going to be able to get this surgery done. Because if you can't help them facilitate their surgery because the lung is constantly in their field pushing them away or interfering with their video image, well, they're going to take hours to finish the case, and the person's going to probably not benefit from that either, from being under general anesthesia for a long time. Because everything we do in general anesthesia, especially with positive pressure ventilation, is never going to be advantageous to the person's ventilation perfusion. So when do you not do it? Again, these are easy questions asked on the quizzes and the tests. Patient refusal, and then large occluding tumors. And they mostly say laryngeal and tracheal, because if the tube is going to be, most of the time, the tube is kind of just, there's two techniques to put the tube in, but both basically require you to just put the tube in past the vocal cords. So if you have tumor in the larynx or in the trachea, no matter which technique you do, you're going to be introducing this overly big double lumen tube into an area that has tumor. So you're going to think about bleeding, right? And then further causing trauma to the structures. Because you pretty much put the tube in so that the tip goes in like right here. So right now it's acting like a single lumen tube, and you could theoretically, maybe it goes like right here. You could theoretically ventilate here because the cuff will still be low enough where you could, and the tube goes to the left, right, because it's double lumen tube. But here's your other cuff. You can ventilate them like you would normally with a single lumen tube. It's just the process of putting that in can cause a significant amount of trauma for someone who has a distorted airway. And also a distorted airway could have tracheal deviation too, right? It can actually have occluding masses at the area where you place that, and putting this tube that has this awkward looking hockey stick to it might not even go in easily. So you always want to have a backup of a normal endotracheal tube to save yourself if you can't get the double lumen in. So a lot of these are actually risk factors for any type of intubation. It's just they're amplified from using a tube that's larger. What you see here is most likely, first of all, so you look at these pictures, and you need to definitely be able to guess where we are on the test. There's definitely hot spots when it comes to that. The hardest thing people struggle with are going to be, where do you clamp on the tube to ventilate where, which is going to cause which side of the lung to rise, and so on. But we're going to get into that. So if I look at this picture right now, I first want to orientate myself. I'm looking at where's left, where's right in the lung. You know that the lungs go from the trachea to the carina, we have the landmark, we have the right, and we have the left main bronchus, right? But if you were to go past the carina, you have additional offshoots. You have the right upper lobe, the middle lobe, the right lower lobe, you have the left upper, left lower. Those are also going to have branches that look like carina. So it's not just as easy as remembering, well, left's right, left's left, right's right. You could be flipped upside down, right? And you could also be distal to the carina, where if you think that's the carina, you're actually too far in, which could be a concern if you're trying to ventilate someone and now you've cut off perhaps ventilation to the right upper lobe. So first of all, is up, and is down, down. Is the picture up the patient's anterior, or is it their posterior? What do you remember back from the anatomy and physiology from Spring or from Dr. Jackson? What are identifying features of the airway? Yep. And where are they located?
Anterior.
Anterior. So anterior being here, superior's here, inferior's down here, posterior's back of my neck. So I'm traveling down through the vocal cords. The first thing I'm going to notice as I'm going down is that if I'm walking along, let's say, the posterior part, is I'm walking on like these longitudinal muscle fibers, okay? And then above me, my roof is these cartilaginous rings. And you could probably think of this in a lot of different ways. That's how I'm thinking of it. And so as I'm walking, I look above me and I should see like rings, like structural rings, like you're in some type of dome. If I see that, then I know that right is going to be right bronchi, main bronchus, and left's going to be left main bronchus. Does that make sense? So where is this laceration or this bronchial tear? Yeah, it's just left to the carina. What kind of tube do you think the people put in?
Left side.
Yeah, it's probably a left double lumen tube. There can be a lot of complications from double lumen tubes. So just remember, these are people with underlying lung pathology almost always. You can have some people who come in with just, random presentations that have normal lung mechanics, because you have think of this a couple of ways. You have mechanical issues with people. So your lungs, do they open and close? Do they passively exhale normally? Are they easy to ventilate and open up, right? Is it like a problem with a thoracic cage impedance to restrictive airway diseases, or is there something wrong with the elasticity of the lungs? And so a mechanical perspective you have to take into consideration, but an underlying disease pathology to the alveolar capillary membrane is another thing you have to take into consideration. So these people, most of these people are at a disadvantage coming in. So when you go under general anesthesia and you do thoracic anesthesia, any little thing that we contribute, and I guess you could call it sort of like an iatrogenic cause, something we don't prepare for, or something that we're not fast at acting on, something that goes wrong that we don't clearly respond to quick enough, we have like a little bit amount of time that we'll correct it before we start to see hypoxia. And so these cases can be quite stressful depending on what you're doing. Especially when you say, okay, well, Mr. or Mrs., sick COPD person with cancer in their lungs, 50-year smoker, 2 packs a day, whatever it is, huffing and puffing, walking up the stairs to pre-op when you go and find them, and they have to tell you to give them a minute to catch your breath. These are the people you're going to probably be the most concerned with. Some will say, too, that these people typically are used to having less than optimal conditions. Okay. But I always kind of take these cases seriously, regardless of what people's sort of perspectives are. So during the cases, if everything goes well, you can still be dealing with hypoxia. So you can still be dealing with patients that don't sat well. But when things don't go well, what do you do in the case of this? How do you recognize these things? So we'll go and start talking about some of these things. So inadequate lung isolation is going to be something that is going to frustrate the surgeon, but if you're not adequately isolating the lung, you're also slightly ventilating the lung, and that's what that means. That's not necessarily going to make you upset because, hey, I've got some more alveolar tissue or surface area, I've got more real estate to be able to ventilate now. It's going to make your life a little bit easier, but it might make the case go longer and the surgeon will start yelling at you. Hypoxemia is really only if you send an ABG off, because you really don't know if someone's getting the adequate amount of diffusion of oxygen across the alveolar capillary membrane. Unless you send an ABG off, I mean, you're looking at which value? PO2. And then you're comparing that value to what you're starting. There's basically a number, a general number we use. So like if I'm supplying an FiO2 of X, my PO2 should be Z. What is that? Yep, so that's, yeah, the ratio is important, but what do we typically say? What's the multiplier of, if I'm giving about 100% of FiO2, what should my PO2 be? About 4 to 5 times. I think it's about 5 times in the actual alveolar space and about 4 to 5 times in the actual PO2. So when I don't see if I don't get what I expected, so I give 80%, I expect 400. If I don't see that on the ABG, something's telling me that even though I'm sending 100% FiO2, I'm not able to get all that oxygen across the alveolar capillary membrane. So something's going on either at the membrane or getting to the membrane, right? Because this is sort of like a balance between delivering the oxygen, because we know we're getting 100%, so you can take that variable out. In this case, we're looking for a 500 for a PO2. So we know we're delivering 100%. We know they should have 500 in a healthy lung, but we know this person is not healthy. And the disparity tells you how significant your hypoxemia is and your potential underlying problems are. So is it a delivery issue getting down to the alveolar capillary membrane, or is it the alveolar capillary membrane itself, or is it a cardiac output issue? What if we send all the oxygen in the world and we have a really nice alveolar capillary membrane, but there's no blood there to accept it and bring it to where it needs to go, which is the heart, the kidney, the brain, the liver, all that stuff, right? So there's like a lot of different things you should be thinking about for why we're having hypoxemia. We talk about the 5 causes of hypoxemia, which helps narrow that down. And this seems like the same thing here on the backward motion versus like herniation of the cuff. But this is now coming from a clinical standpoint. We're trying to problem solve. Like, why is this happening? We have to fix it. So what do you do? How do you recognize these things? This is basically, hey, these are the patients that you're going to deal with. There's a good slide that's in the respiratory overview lecture that I posted that talks about smoking cessation. It has huge implications before doing these cases. It's imperative to be able to get these people to stop smoking. But these are some of the things you have to consider. If you've had really bad pulmonary disease for a while, you probably have also got some other types of cardiac diseases. METs is always a concern with any type of cancer cases. When we do ablations, for instance, and I always like to explain this, just give an idea of how important it is. There's always concern if you instrument someone, go and take out the cancer, that whole tract that you pull that cancer out through could cause cancer to spread, or microcirculation of cancer. It's why ERAS is like a really important thing for all cancer cases, because unfortunately, you guys know the physiology behind like cancer or metastasis, micrometastasis, they say. When you give anesthesia, you inhibit the immune system, which normally would fight those small micrometastatic types of movements of cancer and stuff. So most of our anesthetics do that. The inhalations do it. Propofol seems to not do it as bad. So it's that stunning of the immune system during surgery. What seems to actually preserve NK cells, which are the ones that are going to be going after the tumor cells, is lidocaine infusions seem to be pretty balanced as far as preserving it. And then if we can also not inhibit the immune system by doing types of regional anesthesia, and then thereby reducing our anesthetic levels, that can also help. So quite a few people who get diagnosed with lung cancer. So these are the patients that you're going to see to either provide an operation to help try and cure them and prevent their cancer from causing spread to the nodes and then eventually metastatically around the body, or it could be palliative. So a tumor is actually making it more difficult for them to breathe because it's occluding their airways. These are just looking at rates. Things have obviously gotten better as less and less people smoke. Men typically smoke more than women did. Okay, so here we go into like the anatomy. So the anatomy and why I talked about this picture originally on here is that the right and the left aren't the same. In this picture, you actually do sort of like see it as being the same, but the right side's a little wider and it's shorter, and it goes straight down more than the left does. And so what I mean by that is, the relevance of that is it's more vertical. This one kind of goes off. This is over, I think I'm overdoing the picture here. This is the reason why we aspirate on our right side. It's a bigger chute to throw things down, and it's easier to get directly to. When you're trying to place a double lumen tube or a bronchial blocker is actually pretty hard to place sometimes. It's always going to want to go on the right side. So why is that? Well, it always wants to go on the right side. And these are questions we're going to ask you to understand the anatomy of what's going on. Because it's a reason why you're having a true struggle with putting in the tube. And it might buy you a little bit more time with having a little more time to be able to do the tube without it getting taken away from you because you answered all the questions there. The next thing you think about is that at what point is the first offshoot to a lobe? In the right side, the first offshoot comes the earliest. So this is the right upper lobe. The first offshoot for the left comes much more distally, upper lobe. And so that becomes significant because I've got to take this double lumen tube and I've got to position, there's two sides to it in a sense. There's the bronchial end and then there's the tracheal end where the lumen comes out and you're actually ventilating through it. I've got to put it in one or the other. If it's a left double lumen tube, it has to go in the left. If it's a right, it goes in the right. Very rare when you put right double lumen tubes in, unless we have to take the whole lung out on the left side, or if we're right side, a double lumen tube in. Or if we had some type of cancer on the left main bronchus, we can't put a double lumen tube in. It's probably right where they're going to actually start to cut out, re-stitch, and all that. So, but almost always we're going to do a left double lumen tube for a good reason. They're sort of easier to use and they're safer to put in. They're not easier to put in, but they're easier to maintain. And the reason for that is because that bronchial tip of the double lumen tube has to go slightly into the actual bronchus. Again, in order to isolate it, you need to have a cuff which blows up, right? If I were to put in a left double lumen tube, I have a good chance of the tube and the cuff possibly occluding the right upper lobe. Because the distance there is about 2.5 centimeters from here to here, and it's about 5 centimeters if I got to worry on the left side. So you have a very small amount of room to work with. And now think about this. You're in the middle of a procedure. You've intubated this patient. We know it's difficult. We know there's all these concerns. We can cause lacerations. It's hard to get the tube in. And this is also, too, you can think about this with the bronchial blockers as well, depending on which one you're using. And now everything goes according to plan. You finally get the left double lumen tube in the left side. And now the patient's now being positioned. You're going to turn them on their lateral side. That tube can move. Or the surgeon is physically manipulating the airways and stuff. So let's say it's a right double lumen tube and they're operating on the right side. Now they're on their left side and they're operating on the right side, but the tube's on the right side. Again, surgical manipulation is going to physically push the tube out, or you might have back pressures, right? Let's go back to a left double lumen tube. You could just have airway resistance that causes a lot of intrapleural pressures that might want to migrate that tube out. Most of the time, tubes want to go out, not further, deeper, and in, all depending. What if you're long circuit and the patient's arms and the surgical staff up at the head knocking to the patient, knocking to the airway, knocking to the tubing? You step on the tubing, it might migrate out, right? So it seems like a textbook thing. Oh, okay, yeah, left's this long, right's that long, right up or whatever. But in reality, this is actually almost always why you're starting to desat in the middle of the case, is because there's been some type of tube movement. This is looking from the outside in. Those are kind of like the longitudinal muscle fibers. And then the actual cartilage, the rings we see from the inside looking out, are actual rings. Those are the tracheal rings. So we have a little video here that we can go to. It's actually a simulator. If not, I think I put the simulator online. We'll come back to the simulator during break so we don't mess up the recording. This is another view of the airway. What's up and what's down? Physically in the picture right now, what's at the top of the picture? Right, so it's the posterior side of the airway, that's the muscle fibers, and then at the bottom right now we're looking at the cartilaginous rings of the trachea. If I had to go into the left side with the left double lumen tube, am I going to go right with my tube or am I going to go left?
This view, right?
You're going to go right. Because if you flip the image, we're upside down. So instead of we want to go on the left side, but the left side right now is on the right. So we physically have to put the scope, and we have the fiber optic scope, and we're like, we have the fiber optic scope, and we're trying to get this fiber optic scope in. We're going to try and turn the scope. You use your hand to turn it left. You use your hand to turn it right. Use your thumb down usually is flips up. Push on the control up, and it flips down. So I'm going to just turn, and I'm going to push my scope in to the right. But it's really this preaching's left. We'll come back to west zones of the lung. I think it's a little early to talk about these things. We can talk about distribution of blood. The reason for this is everything comes down to ventilation perfusion. And right now, when you turn the patient on their side, or we turn the patient on their side compared to supine versus sitting up, the distribution of blood flow changes, and the compliance and the distribution of ventilation changes as well. So that's normal, right? No matter where you are, and this is assuming that you're not under general anesthesia, and it's assuming that you're not muscle relaxed, and it's assuming that you're not under positive pressure ventilation. Now we're going to complicate things by putting you under general anesthesia, and then we're also going to then even make it more complicated. We're actually going to stop ventilating one side of your lung. But while we stop ventilating, did the body stop perfusing? No, right? We can't tell the body to stop perfusing. If I perfuse an area with no ventilation, what have I created? A real shunt. Yeah, no ventilation, but perfusion is a real shunt. And that's when you go back to west zones of the lung. Shunt is something that I always say is theoretical. It's not theoretical. It's something that can happen, but a total shunt's never really, hopefully we're never really dealing with that. It's really not good. Most of the time we're dealing with a mismatch of ventilation perfusion, which means that we're sort of going towards shunting, or we're sort of going towards, what's the other one? Dead space, right? It's never extremes, hopefully. So, and we could have dead space, like extreme dead space, and that could be possible if the artery that's going to the lungs is clamped, but we're still ventilating that lung for some reason. Well, then obviously we're ventilating something that has no blood, right? Okay, so normal anatomy, we typically have more lung tissue on which side? The right. So what do you think? We have more blood flow on the right? Correct? if we were to place people on the right lateral decubitus position, as far as blood flow goes, if you're on the right lateral, you're going to have disproportionately more blood going always to the dependent side, but it's going to have more blood flow going to the right side because in this case, the right side has more tissue and it's dependent. And then if you switch someone to the left side, the blood flow to the left dependent lung, because you're laying on your left side, is still going to be more, but not in the same ratio. So the reason why I find this always interesting is if you are right lung dependent and you're operating on what side? They're not going to operate on the dependent side ever. That doesn't make sense, right? So I'm laying on my right side, I'm being operated on my left side, and now I'm assuming I've dropped the left lung, so we're not ventilating it. Which one's going to have more VQ mismatching? The person getting operated on the left side or on the right side? Less on the right side. And the reason for that is as you, hold on, we're going to use our laser pointer. So the reason for that is right now, 65% of my blood flow, if I'm operating on the left lung, and this is where it gets so confusing with the words, right, is getting ventilated. This is getting ventilated. The 35 is not getting ventilated. If I'm operating on my right lung, I'm in my left lateral decubitus position, and my left lung is only getting 55%. So 55% is getting ventilated, 45% theoretically is shunting, theoretically. I say theoretically because there's something that we do naturally in these situations which helps reduce this a little bit more than the truly 45%. And what's that? Or 35%? HPV, right. This is approximations. So how much does HPV decrease the blood flow to the lung that's not being ventilated? It's right there, 50%, right? So we further reduce that normal anatomical blood flow switch changes by HPV. So now we have less blood. So remember, as you're sending, use a blue marker, as you're sending oxygen to the blood, we'll say this is the, it's like this. This is again, right side, patient's right. This is not how the heart looks. I hope no one ever draws this. Left. Oxygen for blood goes to the lungs. And we could say lungs give O2, so we could say, you know, that's what they're going to be clear and red. And then oxygen-rich blood goes back to the lungs, right? So a shunt is effectively sending, bypassing the lungs, effectively in a sense. They're not getting oxygenated, and you're dumping blue blood with red blood, which makes, what's blue plus red make? Purple, right? And you know, kid stuff. But what you're doing is you're diluting out the oxygen-rich blood, and therefore you could be contributing to the fact that they're hypoxemic, their saturation's lower and stuff, because now maybe your shunt's like 10% of a shunt, so you're diluting, instead of fully oxygenating your blood from blood going through the capillary membrane, right? This would be kind of like, here's your capillary membrane right here, and then coming out on the other side, and you're getting a 500 for PO2 with 100% FiO2, and your saturation on your pulse oximeter is reading 100%, you might now start seeing, and you look at your oxyhemoglobin curve, right, for based on what your PO2 is and your O2 saturation, you're going to start to see that sort of disassociation where you're not getting the maximum amount of ventilation perfusion, because no matter how hard you try and ventilate these lungs, some of it is not going to play nice. It's not going to play ball. It's not going to go through the right mechanisms to be oxygenated. So no matter how hard you play, you're always diluting down what could have been, you know, 100% or 500 for a PO2. So one way that the surgeons can eliminate that, and I think there's a PowerPoint slide that comes up soon, is you can simply shut off blood flow to the lung that you're operating on. And then thereby blood flow from the right heart only has one place to go, which is to the other lung. And if you send all the blood flow to the one good lung, now what do you think you have to increase in order to compensate for the increased blood flow? The volume now. This is not, we don't care about pressure. This is the volume of blood that's showing up. I have to now feed, instead of 10 people for my party on the weekend, I'm having a barbecue, guys, this weekend. I gotta feed 20 people. What do you think I need more of? I need more food. In this case, I need more oxygen. If you look at the alveolar capillary membrane, the membrane actually does this in a couple ways. The time distance of like start to finish is so efficient that in the first third, usually you're already oxygenating the blood as it goes through. So now we have another 2/3 of the distance to kind of be like, okay, let's get more oxygen on. We can ventilate more, right? We can just increase our minute ventilation, right? Which means, hey, get O2 in, get CO2 out. Get O2 in, get CO2 out. We can re-recruit that left lung, because what if that left lung is normally, what if that left lung, after positive pressure ventilation, after 3 minutes of trying to get double lumen tube in, you've collapsed a bunch of alveoli and this person's already kind of like allostatic and stuff. Well, how do we get more space to ventilate more oxygen into this more amount of blood that's coming? Because the blood's here, but you don't got oxygen. So how do I facilitate more oxygen to the blood? How do I get those hamburgers out quicker? I buy more grills, right? I get a couple more people working the grills. I can produce 100 hamburgers a minute versus 50 hamburgers a minute, right? So what you can do is you just gotta recruit somebody. You gotta recruit, your friends to come over and cook with you, because you're only one person. So if I do some positive pressure and some PEEP, some airway maneuvers, if I do like 20 to 30, breath hold them for maybe 30 seconds and stuff, vital capacity breaths, I can say, okay, yeah, that lung is real small, because this is just like say circumferential area, circumference of let's say the lung, and it's kind of sagged down a little bit because we've de-recruited a ton, right? But if I start to give those big vital capacity breaths, I put on 8-10 centimeters of water of PEEP, maybe my surface area then goes to here. I now have more space for capillary alveolar membrane and oxygenation, right? So now I can keep up with maybe the 10 liters of blood flow a minute going through that one side versus the 5 liters. So ventilation becomes an issue with a lot of these patients because, again, we're trying to ventilate lungs that are in different stages of compliance. So these graphs talk about the compliance. So this is a compliance curve. So the most compliant you'll ever be is usually oh, I didn't stop anything, is probably right here. It's where very little, and this is how you read this curve. And so I do put pictures of curves in the test to see if you understand what you're reading, because then you understand the greater concepts. So what you can interpret from here is, if I start here, and let's just pretend let's have imaginary lines of 5, 10, 15, whatever. So 5, if I get 5 centimeters of pressure, I barely get any volume, because this is volume, this is pressure. 5, from here to 10, I add 5. I get nothing for volume. That would mean it's not very compliant, right? But as soon as I'm at the, say, 15 mark to the 20 mark right here, my volumes are great. I found that sort of threshold to pop those lungs open and actually finally get real volume of air in. You can shoot pressure at someone all day, you can blow into a balloon, but you know that's at a certain point where you put enough pressure when you deal with those party balloons that the balloon finally inflates, right? And then it turns into a big balloon, and that's basically the tidal volumes you're looking for, vital capacity breaths, whatever it is. So there's a sweet spot between here and here. After this, you can blow and blow into that balloon, but the balloon's either going to pop or it's going to do nothing. And you're just not going to be strong enough to keep blowing the balloon up further and stuff. So up at the top of this margins, you would say that you have, really not a great amount of compliance. You don't have a great amount of compliance here either, because you're really not getting a lot of volume. So it's sort of confusing. You have the greatest amount of potential right here if you can find that sweet inflection point to get that curve to go up. but you really are going to have much more wiggle room here. And that inflection point basically is when you're starting to think about over-distension of the alveolar spaces and stuff, which is going to cause what kind of trauma? Barotrauma, right? Or volume trauma, depending on how you look at it. But barotrauma being pressure, volume trauma being too much volume, but too much volume is going to eventually cause high pressure. So it's all kind of like the same thing. Just different ways they can categorize putting a great effort for nothing. You're not going to get a lot out of being at the top of that curve. So these graphs actually tell you like, hey, this is the awake person. This is the anesthetized person. It's telling you that the non-dependent lung, which is always the lung that's being operated on, and the down lung, which is the dependent lung, just kind of get those terms. And this is a great topic, the group study, just to make sure you're getting this right. What I see here is that once you anesthetize someone, I lose a lot of potential in the sense of like, hey, it's going to take a lot of effort to get that great compliance with that down lung. So yes, it has potential, but it's going to take quite a bit of work to kind of get it into the sweet spot, which is this from right here to right here. That sweet vertical takeoff, just like Bezos did. Bezos or Bezos? Shot up to the moon and back, right? Do you know that the kid that was on there, 18 years old, the original bidder for that, like, had to back out. The next bidder got it. It was a gift from his dad. $18 million. Right? $18 million. Like, here you go, kiddo. Get on a rocket with Jeff Bezos and go to space. What would you guys do with $18 million? Would you even be here right now? Yeah, maybe not. Okay, so now it's another graph that comes in play with like, okay, what is the clinical relevance of this down? Why is it this down lung got worse? The down lung was like the most, this down lung on the awake patient was someone that we could probably like get some extra compliance out of. We could really get some more volume into. And then the up lung on the lateral position is like, why waste your time? They're already sort of in that like, they're already probably have enough air in them, but you can't get that much more air. We look at the wet zones of the lung. What you typically are looking at, and this sort of is a good way to kind of like go back to this. Do we remember wet zones in the lung from spring? Yeah, okay. So like wet zones in the lung kind of say like, here's your lung. This is probably in an upright position. There's these like three, sometimes say there's a pathological 4 zones. You have 1, you have 2, you have 3, right? And they draw these pictures of the alveoli here. And you see the alveoli here is like small, this is like medium, and this one is like big, right? And then there's like the blood side that comes in. You have blood vessels that come in, technically. Oh, I have the caps wrong. I was wondering why this is not right. I guess arterial is actually like blue because it's oxygen depleted, right? And then on the other side you have like the red, right, that comes out. And if you had a close-up view of this, assuming that this kind of changes based on where in the zone you are, 1, 2, or 3, we're looking at this interface that's right here, where you have artery. This is the magical capillary beds right here, right? As it transitions to the venous pulmonary veins, or it could be technically eventually, like these are all very small vessels and stuff we're talking about. But all right here is that capillary membrane. And so the wet zones in the lung tell you a lot about the relationship of this alveoli, and that's a surrogate to like all of your sort of entire lung. Big A, right? And what's your relationship, the ventilation-perfusion relationship between how much you ventilate and how much blood, hopefully the right amount of volume of blood goes by, and how well is that interface of little oxygen molecules going back and forth? And what else is going back and forth? CO2. Yeah. So you have CO2 and you have O2. There's probably more going on, but that's basically what we're talking about. So how does this relate? So this could be something like on a test and stuff. Like I found a way to ask a question that sort of like applies this knowledge into that, right? Or into a scenario of a patient that's being 1 lung ventilated. So the awake patient, we're gonna go with awake. We're gonna go with like someone who's like normal anatomy, normal physiology, keep this simple. This is assuming sort of like normal anatomy, normal physiology. At any given time, like various parts of your body have various zones of the West zones going on. Don't oversimplify and think that it's only when I'm standing right now that zone 1 is here, and zone 2 is here, and zone 3 is here. It's always a continual change in like in the underlying physiology, because you could have an airway occluded by a tumor. You could have atelectasis from someone who's older probably, who's like not been out of bed for a couple days and stuff. So again, all these things could be different. You could have pneumonia in one lobe of the lung, right? So that would be a whole different type of West zone than the rest of the body. And we manipulate these West zones too with how we either ventilate or don't ventilate someone, or we clamp arteries, or there's PEs too, right? So if I look up here and I say the upper lung of the awake patient is basically right here. So I have someone that has quite a full volume of air in the alveoli. That's like the balloon that's already blown up. I can't increase the size of that balloon that much because it's already kind of, it's like maximal point. So I can blow, 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 put tons of pressure in, but if I don't get lots of volume out, am I compliant or not compliant? I'm not very compliant, because compliance is all about putting in small amounts of pressure, small pressure right here, but big volume. Y-axis is big volume for small changes going from here to here. Small change in pressure, tons of return for your money, which is you get a lot of volume. This West zone's number 1 is basically this up lung right here. Because if you think about it, the person in the lateral decubitus position is laying on their side, and the dependency of everything in their body is putting all the pressure here, making it very difficult to keep those alveoli open, right? But up here, there isn't a lot of extrinsic pressures keeping that alveoli open. Now, if my heart's like right here, is it easier to pump pressure to the 3rd floor or down the basement? Basement, right? Gravity, blood flow goes there, assuming that all your vessels are normal, there's no atherosclerosis. You don't have local reasons why it's going to cause hypertension, right? Like COPD patients or someone who's hypoxemic and stuff. But yeah, so here, our vessels, or our blood flow is bigger, smaller, and even smaller. So there's your ventilation perfusion mismatching. More ventilation, less perfusion. So here, I can ventilate a lot. I might have to get a ton of volume because I'm kind of already maxed out, but I don't have great perfusion. Here's the most ideal, which is zone 2, where a pretty reasonable amount of ventilation is matched perfectly with a pretty reasonable amount of perfusion. And down here, I've got tons of blood. I got tons of blood, but I've got tons of people to feed. So here, we want more people to come to the party, right? So we probably have more potential to recruit down here than anywhere else. Because that alveoli can open to as big as number 1 is, but it's just going to take a little more work. So the down lung here on the anesthesia person changes. So this is the normal down lung, which is like normally like probably like, you know, zone 3. This down lung is in zone 3. There's really no other zone to go to. But in order to get it to an optimal place in zone 2, it needs a ton more work, because on this curve, it's not that compliant right now without having enough pressure. So the physiological reason why you think that is what happens when we muscle relax, we put someone to sleep, and we like, even if you just have SIBO on, what's the downside to paralysis? What normally helps pull sort of like, keeps your thoracic cape sort of like, what do you normally breathe with? What muscle? Diaphragm. What happens when you paralyze your diaphragm? It kind of goes upwards, right? You're laying on your side, where's your stomach go? And where's your stomach contents? It goes upwards, right? So that's the reason why like this down lung started off pretty good. Start off in this like beautiful recruitable area where you can give like very minimal amounts of pressures to ventilate them and they get great volumes. to where it gets really crappy quickly because you've anesthetized them. And now the surgeon's pushing down on the top of the non-dependent side as well. I'll finish these graphs and then we'll take a break. Okay, so this one is another picture. Basically, if you open the chest, you're going to get more compliance in the non-dependent lung. So that's what that's showing. You don't see too many stark differences here. You're also, one of the other things you have to think about too is when you're doing a closed chest versus an open chest, you know, you're going to have pretty good compliance because now that lung is not impeded by a thoracic cage. But now if you do a closed chest, what they're talking about is like laparoscopic. You're going to put a couple of like 3 holes in their chest. You're going to go in with a camera. You're going to go in with an instrument, and then you're going to go in with a trocanter that can introduce CO2 insufflation. That's going to cause a pneumo in the chest, right? Not in the pleural space, but in the chest. If you not only have someone pushing from the top, but they're actually causing like pressure inside the thoracic cage, what do you think that's going to do to the dependent side that you're ventilating? It's going to push the mediastinum and everything down, right? So it's going to make it even more non-compliant. So I don't know why I wish there was a way to kind of show this in the closed chest being worse than being in the down chest for the open case, because you would think it would be worse, but that's just the pictures we have to work with. Again, because there's a pneumo from the up lung being operated pushing down on all those central structures and making it even harder to ventilate this. And here, it's wide open. There's no pneumo pushing down because we're not insufflating it like we do the abdomen. Take a break. Oh, now we're recording. Okay, so you need the rentoscope. Mac blade's better. Glide scope's the best. The glide scope's going to be thicker when you put that glide scope in, so you're going to have less room to get the tube in though. So just, you know, there's a trade-off there. Clamp. Be careful you don't cut through the tubing with it if it's not a decent clamp. You do need a fiber optic bronchoscope, and you need one that's going to be able to fit into the tube so you can go down it. When you're preparing a fiber optic bronchoscope, you want to make sure it turns on, that you have good image. I always like to see the clarity of the image, whether it's a glide scope, fiber optic bronchoscope. You want to look at some writing on the packaging. I think that's the easiest thing. You know, if you can read the Cook Medical on here, if you can see that, you're probably going to have a decent view inside the patient. You can pre-treat the actual video or the camera with a solution that they have. There's special solution that they sell, which is like for lubricating the scope, which I recommend as well. The scope, you want to make sure the scope functions. The volume goes up and down, and the scope, you know, looks like it's obviously intact, it's working, it turns on, or you can physically see through it if it's an old school one. And in addition to that, you probably want to hook up suction to it or hook up air to it. Suction's going to clear things that get in your way, like if you have a mucus plug. It could also allow you to flush through. But air also is nice because if you put air through it, it helps with keeping the scope kind of clear from obstructions of whatever's inside the lungs. If you go in with a bronchoscope and your image is crap because you've got like secretions or something on it, one other thing you can do with the scope, so that I'm not holding the tube, but one other thing you can do with the scope, which works really well, is you can gently touch the mucosa of the trachea or the bronchus, and that will usually clean your scope. Just kind of touch it, come back, get your view. We don't always have to put in a double lumen tube, so we have bronchial blockers, which are also an option. This is a Cook device, I think. No, this is called the Easy Blocker. This is one of many different types of bronchial blockers. So what you would do is you put a normal breathing tube in, just like anyone else. Same exact process. Once that tube's in this case with this bronchial blocker, you can pretty much just thread this through the tube, take off the plastic housing though.
Okay, when I have the piece, if you want it, I think.
Oh.
It says the Easy Blocker.
That is what that is. I wonder what that was. That must be it, I guess. Yeah. Let's see. I didn't have this last year because we had to teach more online. So here's the easy block. Right? Just get familiar with your equipment. So I intubate, I take that silent out, I ventilate and make sure I'm oxygenating, all that stuff. And then when it's come time to isolate the lung, I think I have to break this off. I guess I don't know why I didn't break it off before. This is trash. Okay. So there's also another piece that's supposed to go on here. I want you to see that as well. If you look in that box up there, there's a piece that could go in here for like some passive insufflation. Now every device is different, but basically the premise is, here, let's do this too. Let's draw the lungs, and then I superimpose these devices on the lungs. There you go, make all my life a little easier. So I have the left MAINSTEM, and then I have sort of the right before your first offshoot. Your right upper. Your left upper. Okay. All right, so my tube. Okay. So here's my tube. It's sitting right below the vocal cords. Vocal cords, just so you guys have an idea. This is the vocal cords. All right. Here's my tube. The cuff should be like right below the vocal cords. Doesn't matter what kind of tube it is, it's all the same. Coming out of the patient's mouth. I then stick in this device afterwards. First, I put the adapter on. I stick in the top ear. I can then twist this on. This is basically going to keep it from moving once you clamp it down. Then also, you can kind of seal it, and you have to seal it. So you don't want to put it on too tight because it won't go through, but it's on. You probably want to lubricate this too. I'll probably push this all the way down. So I'm pushing this down, the patient intubated. Push, push, push. And then normally at this point, once that goes through, the yellow is a little bit skinnier than the end. This is obviously pretty thick. I now can share the scope with a bronchoscope. So this other port here has a little cap, so you're including the area where you're not using the scope. And then you think it would have also like a little screw or something more permanent, but I'm ventilating, like when I'm doing a bronch, I'm ventilating through the side port. I take my bronchoscope, I insert the bronchoscope through this extra port, and I get you'll watch on the camera watching this, or if it's just a little eyepiece, you're watching until you see your cuff, and then you usually can see the Murphy eye right here, Murphy eye, and then you pop out of the tube. And you're looking at now, you're just staring at this. And now we know the anatomy of the lungs. We see the cartilaginous rings, we see the muscles, and now we're just watching it place this. So now I'm here, and I'm my scope, assuming that this is what we're looking at, like this, right? So now I draw that. Balloon. That. My scope is like right here. And then, do like lots of colors. We should do yellow, right? We have yellow. See. All right, who would have thought I'd ever use yellow? So here's this yellow piece that's like our thing, and this is coming off like that, right? So we're watching to do is, because we're watching to see this get seated in the right side that we want to include. Now with this thing, this is nice because there's actually two balloons on here, and it corresponds to these two things too. I don't know. I think basically this is more yellow, that's more blue. I would test these balloons like you test your endotracheal tubes ahead of time, just to make sure they inflate and hold. When you test it with air, you have to take a syringe off, because not only do you want to make sure that there's no air leak here or in the line or in the cup, but you want to also make sure this little pilot thing also doesn't leak. So if you leave the syringe on, you won't know that because the syringe off, because the pilot will close afterwards. But it should correlate. It doesn't matter which side the yellow goes or the blue goes. What you're looking for is for this to go and hug the carina. So go in, it's going to hug the carina like that. Then you notice with the fiber optic scope, again, looking up from above, as you're looking down, I don't care which side goes where. I need to know which side is the side that I need to include. So if I want to include, so in this case, we have the yellow goes right here, and let's say the blue. The blue goes here. So if you see a picture on the test, I see a picture on the test, and I say, okay, well, we're going to ventilate we want to do operations on the right side. Which balloon would you inflate as a CRNA? So start off by saying, okay, where's right, where's left? If I show you an image of a fiber optic bronchoscope, you're going to have to know the actual what you're looking at. But if I showed you this picture, which of these would you inflate? If it had a hot spot on it, which one would you inflate? I'm operating on the right lung. So which lung am I dropping? The right lung. You don't want air in the right lung. You don't want the lungs opening and closing with ventilation, so you would inflate the right side, right? So I put air in here. I don't know. It's probably somewhere with the same amount of cc's of air, like 2 cc's. You try and keep it really low. So I inflate the right. What would I do with the left? Or the blue in this case? Now remember, this could flip and turn the other way, and now it's the opposite, right? So you have to know what you're looking at. What do you do with the other one? Because I could ask a question where it's an obvious answer, but it's like a weird question, and I'm sort of like, how many cc's would you inflate the blue cup in this situation? 0, 1, 2, 3, or 4. You'd be like, well, normally inflate like around 1.5 cc's, maybe 2, enough to cause like an occlusion. So you'd be like 2, 0. See, I'm misleading you. I'm leading you down the wrong path. So you inflate which balloon? We're doing right side again. Operation on the right side, we're inflating which balloon? You said it. Right side, which is which one in this case? You're physically looking at which one is it? Yellow or is it the blue? Yellow. It's yellow. So now, which side here do you leave open to ventilate atmospheric pressure, and which one do you close? I can ask another way. Which one is, if left open, is going to cause a leak on your circuit when you're trying to ventilate the good lung that's not being operated on? Because both of these have a little hole, and they can allow air out. You include that left lung, that right lung, let's say, you gotta get the air out. I mean, what good is it if you just left it under positive pressure and you said, all right, good luck, it won't move, but it's full. So which one? Same scenario. We're operating on the right lung. So here's our knife. A little 6-blade knife right there. Serrated, whatever you want to say. Which one? And we'll go based on blue and yellow. Which one's going to be, cap is off, there's no cap on here, maybe it's the thing. Which one would I put a cap?
Cap on would be blue.
Would be blue. Because blue, in this case, this is not, there's a blue cup here, but we never inflated it. And then in the case of the tube, or of air, I guess we could say air, this is going to get inflated, so let's draw it up. This is inflated, right? And then air, which is orange in this case, because that's what I'm holding. Air, you take the bronchoscope out, right? You did the right thing, you took the bronchoscope out, you know where it is. You leave the bronchial blocker. The air is going to come in, some turbulence around here. The air is going to go past this blue cup that's not inflated, and it's going to ventilate the left lung. right? And then when the patient exhales, it's going to go the opposite way. It's going to go back into the single lumen tube. But we need to let air out of this lung because it's inflated. So you're going to leave the yellow side port open. You're going to cap the blue side, okay? So there's like different ways to ask this.
Is this, are you still talking about when you're operating on the right lung?
Yep.
So when you're operating on the right lung, you inflate the right side.
When you're operating on the right lung, you're going to occlude the right side with the bronchial blocker.
Okay. And then the left side.
If you're going to operate on the left lung, you're going to put the bronchial blocker on the left side. This one's fancy because there's two balloons. You have uni blockers, which is just one balloon. Then you have to really struggle to get that balloon on the side that you want to operate on. And which side do you think it's easy? Which side do you think the bronchial blocker wants to go on? On the right. So you better like your bronchial blockers would be easier to do if you're going to be doing a right-sided lung for operations versus the left. But you can make it work. So if we have a double lumen tube, it gets more complicated, which we'll talk about in a second. Like, whoa, which one do you clamp, you don't clamp, which cuffs do you put up, do you not put up and stuff. That gets a little bit more complicated. So we have right-sided, left-sided. Because that angle's a little different with that left offshoot, we see the tubes a little different too. I think in this picture, we're just showing you what side is being operated on. Yeah, what side's being operated on. And I don't know what this picture's trying to show, to be honest, but I can just tell you what I'm looking at this picture. This left-sided tube, you just notice that the offshoot of the first upper lobe is further down 5 centimeters on the right side. It's really quick where you get that right upper lobe. And you can see how you could be occluding that right upper lobe with the balloon pretty easily if you're not paying attention. You have the tube going around right now, so I'll put this stuff down. Bronchial blocker. And you have double tube. I'm going to take out the stylet so that we can get it ready to ventilate through. So if you're not doing anything crazy, you're not like doing any type of one lung ventilation stuff, all the ports should be closed, right? Close these ports, ventilate through this like this 2-to-1 adapter. We'll talk more about it. Let's just see if so this is another tube. This one's built with its own bronchial blocker. It's a single bronchial blocker, so this one you have to be careful and find like a happy place to put that bronchial blocker. It's in the right location, whether it's right or left and stuff. Oh, the reason why bronchial blockers, there's like pros and cons. So so first of all, trying to ventilate air through that little bronchial blocker to let the lung go down is really hard. And sometimes during cases we have to reventilate that lung because something goes wrong, because the surgeon wants to see how their anastomosis looks. And then they're like, oh, like the lung's not down. You're like, I know it's a bronchial blocker, and they get frustrated because everyone's rushing and stuff. So that's one of the reasons that bronchial blockers have a disadvantage and annoys people. The other thing is well, hey, look, this big tube is going to definitely cause a lot of laryngeal edema, trauma, a lot of risk. And if you have to go to the ICU afterwards, and let's say you're not taking out an entire lung, even if you are taking an entire lung, and they remain not candidates to extubate, do you really think that patient's going to wake up once he's weaned sedation ICU with this thing in? Or do you think it would have been nicer to have a single lumen tube in? So, what's more stimulating your airway? So, bronchial blockers are great because at the end of the case, I got a single lumen tube in. I just got to pretty much just drop the balloons. Take this out. Notice I lost my little piece here. These pieces are always loose. Put those on really tight on any case you do. When you go to open your tube to check the cuffs, make sure that little adapter that goes in here is always on tight. So it just popped off, but whatever. You would notice it when you go to hook up. I got a normal tube in. Bring them to the ICU. Life is great. If they end up not being extubatable and you send them, or you're going to send them to the ICU, which most patients are going to go to ICU anyways, you can do a tube exchange. So has anyone ever exchanged a tube before? No? Oh, okay, let's talk about Okay, pass this around. Remember, this is my look-see bronchoscope port right here. If you're not, you don't have a scope in, and when you have a scope in, just like bronchoscopy, you're leaking. Doesn't matter, you're leaking. It fits around the rubber thing, but you're gonna leak through this gasket. You gotta close it when you're not. Otherwise, if you forget to, you're not ventilating. You're not getting your tidal volume, so everything's lowering and stuff. So, you know, problem solved, right? If there's a question talking about you're having a leak, and it's asking you, like, you know, what the, you look at the picture, maybe it's like an entire operating room, and you're looking at the picture, you know, this might be off. And the question asks you, like, you know, what's wrong? You could say, like, maybe they're not getting a tidal volume. Maybe the picture shows how it's 500 or 350 and stuff. I ask you to pause for it and be able to determine that it's this, right? Do you see how we can apply these things? All right, and then here, this cap. Once this is in the right position, you want it to stay, so you lock it down like this, and then notice as you pass it around, it doesn't move. If you're no longer one lung ventilation because this thing's moved, just maybe position, whatever it is. If I extend my neck, does my tube go deeper or further away? And if I chin down, do I go deeper or further away? Because neck ventilation actually does change the direction or the placement of the tube. So head extension, deeper or shallower? Shallower. Flexion. Turn the patient, their head's sloppy, right? A lot of things can happen. Pediatrics especially, don't have a lot of distance, and they really just in their heads. So yeah, so maybe this is locked, and then things happen, don't blame yourselves. But every time you turn a patient, you always go back and look. Every time you have something that you're questionable, the first thing you do before you go look is you do what? This will be a PowerPoint slide. What do you think the most obvious thing is when you don't know what's going on and something's not right? What would you do normally? What would you do with patients like not sad great or like living in the room just, oh my god, they extubate themselves? What's the first thing you do in the ventilator? I know some places we pretty much have ventilators, but where I work, we do ventilators too. 100% F5 buy yourself some time, and then the next thing to do is double the alveolar capillary membrane space that you're ventilating by going up on both lungs, right? Like, hey, having problems, we're gonna ventilate that lung, tell the surgeon, hold up, right? Then go in and look, and call it out, you know, something like that. Okay, so definitely think of those things as you see that being passed around. All right, so this is one option. I do want you guys to be familiar with a single bronchial blocker and the double bronchial blocker because it does add a little more complexity, which is good. That last slide would be be no different than having a single lumen bronchial blocker. I don't care if you know these specifically and stuff. The application of it, the principles are basically the same. These are just different devices. You don't need to know like those exact ones. The Univet again is just a special one, but you just know that this is a single lumen bronchial blocker, so you only have one cuff to put into one side to occlude that. And which is that? It's the operative side, which is normally the dependent or non-dependent side in the lateral position. Non-dependent, right? Because you can't operate on people when they're laying on the side you're trying to operate on. Good luck. Okay, so pros and cons. So we talked about a lot of these things. Slower lung collapse, you can't really suction out of it and stuff, you know. Less traumatic with the bronchial blocker. All right, so how do you place a double lumen tube? So we've kind of gone back to double lumen tube. All right, so when you're putting a double lumen tube, you have to have probably have the satellite in. I think it's gonna help. I mean, your call. You're gonna use the glide scope. You're gonna use this, you know, back blade. Oh, this has actually got like lubricant on it. It's pretty gross. We used to actually, like 2 years ago before COVID, I did like practical stations, so that was like part of the class, and we would assign practical stations to be able to do these things, to learn them, you know, on like a station day or whatever. Okay, so we put this in with the tip facing up, okay? Goes in, normal DL, tip facing up, cuff goes, as you get it towards like the tracheal, the vocal cords, you probably want to take the stylet out, right? You don't want to push it past the cords with the stylet in. It's like no different with the than with the normal intubations. There's always a risk of using stylets of causing damage. If you cannot use a stylet, that's good, but these are probably rare that you can get these in without a stylet. So you get them right to the cords, and then you take the stylet out. So the bronchial cup gets to the cords, you take the stylet out, you push it past the cords, right? So now you're sitting just past the cords right here, facing up, and now you have two choices. One, ventilate, and just take your time. So which cuff do I put up? Blue or white? Blue is bronchial, white is tracheal. Tracheal, right? So I put the tracheal cuff up, ventilate, get ready. The next step is I can just seat this thing blindly, which is I drop the tracheal. So most times you just put it right in. But anyways, you would drop the tracheal cuff, and you're going to push it in and turn it to the, rotate it 90 degrees to the left. It's a left lumen tube. So I go in pointing towards their stomach, the interior. I then rotate 90 degrees and push it in. It normally will go in to the left. I know that the right is like easier to go down, but you're physically, the patient's right in front of you. Like that's left, that's right. It's not that hard. And as you push it in without a stylet, you go to the left, and it usually goes right into the left lumen. The other way to do things is to put a bronchoscope down. So the cuff is up. I put my bronchoscope down. I can do it one of two ways. I can go down. This is the tracheal. You guys notice when I went around that this is the tracheal hole. That's the bronchial. So what you can do is you can go down the tracheal hole, and now my scope is right here, and I'm watching what's going on with that bronchial tip, and I can see that tip as I pass the scope go into the left side. Or you can go down the bronchial and physically with your scope go down the left side and then pass the tube over like Fuji. You do one or the other. I think most of the time I've always just gone down the tracheal and stuff. I don't know if one's better than the other, to be honest, but you could do either. Help facilitate it going down the left side. Does that make sense so far? So now you're on the left side. How far do you go with the tube? This is a question of like, well, we don't want it to herniate, right? So typically, you'll see an image on here. You want to be able to see just a little bit of the cuff up against the carina, and that's it. You don't want it so far that you don't see the cuff, or it's got a lot of space between the carina and the cuff on the left side. So we also need a fiber optic scope. This is a pediatric fiber optic scope. That's not a video. This is you literally looking in this little glass thing, and you're watching, you're manipulating. No one else knows what you're doing. Just showing you again where you are spatially with the anatomy, and then also just showing you on the left picture, middle picture, that we could be doing these for different reasons for the fiber optic. So proper placement left side double lumen tube is going to be this could probably go in a little bit, but this is acceptable. So now you're problem solving while you're hypoxic. Again, you're going to go in and look after you go up 100%, put both lungs up if it's an emergency. If it's not an emergency, but you just want to problem solve, I'd still go up 100%. I wouldn't go to two lung ventilation if I feel confident I can go in, because you now go in through the viewing ports right here, or the suction ports, or the exhaust ports. These do a lot of different things. You go down the right side, the appropriate side that you're looking at for what you're trying to do, and you're going to be letting air out. You're going to be exhausting the air you're trying to ventilate the good lung with. So you don't have a lot of time where you're not adequately ventilating that you might run into problems. Just the thing, like, can this patient tolerate that? But you go down quick, you look, is the tube in the right spot? And if it's not, what are you going to do about it? This is a very dramatic picture of a herniation. Like, it never herniates like that. Herniations happen all the time for normal breathing tubes and with these. This is much more sensitive to be displaced. I actually had a pediatric herniation 2 days ago in the OR. Luckily, there was no emergency and stuff, but it would have been if we lost our airway and the patient desatted. But again, wasn't getting my tidal volumes, and I heard a little bit of a leak, and you don't really know what's going on. And I looked at the tube, I looked at the child's age, and basically, how do you guys determine like tube depth with age? Or tube depth. How do you guys know how to calculate the actual size of the endotracheal tube for pediatrics?
16 is the age that I have born.
I don't know that. I expect it to be it. 60 shades of what?
Plus their age divided by 4.
right, so 4-year-old, what size tube?
Probably 5, right?
5?
Half size smaller. A cup.
Good, good. Why do you know that?
I was on one of the quizzes in the spring.
Oh, good.
And it came up.
Great. Oh, that's right. Yeah, there's right. Good. Perfect. So his thing works. Mine's usually age divided by 4 plus 4. So 4-year-old, 4 is 1 plus 4 is size 5-2. Drop it down to accommodate the cough. So the tube that you choose should be about 3 times. So times it by 3 is the distance and stuff. So this patient was like, I don't know, I think she was 5 years old. So the tube I put in, I think was like a 4.5. And so 4.5 would be what? Times by 3 would be like 12, 13.5. She was 15. So I'm like, well, it can't be herniated. You know, she's 15, she's deep. So I put a little bit of air in, leak went away. Again, I'm thinking herniation too. It's always like in that realm of possibilities, like this. Scene 5, I'm ventilating and I notice a change in compliance because we typically ventilate pediatric patients in pressure control settings. One, it eliminates the chance that you accidentally put them on the normal backup of like 10, 500, which is the adult, and you like cause volume trauma, right? And then 2, I don't know what 2 is, but that's probably one of the main reasons. So we usually do pressure control settings. The problem with pressure control is that the volumes are variable, so when you actually are ventilating, you don't know when there's a leak. You don't really know unless you're paying attention to what your compliance is and or the tidal volumes you're getting for that set pressure. I noticed my volumes changed when they shouldn't, and they also could change too based on if they're assist, if they're on PSV Pro or if they're on just straight mechanical pressure control. This person was spontaneous, so again, it could vary. And so I realized that really the compliance changed. And so I went back, had them stop, look, it was a dental case, listening to the airway and stuff. And I put her on purposely volume control to give 150 cc tidal volumes. And I was getting back like 90, so there was a leak. At that point, we already put air in it, and what do you think I did? How would you problem solve this? Because it could be this tube that's leaking from here, or it could be leaking from here. What would you do? Would you just put more air into it? It might fix the problem temporarily if it's herniation. But how else would you know if the tube's in? How did you know the tube was in the first place? You looked, right? So I looked quickly with a Mac blade. I could see a cuff, like a big part of the cuff. And then we got a glide scope to kind of so everyone could see, and it was like almost completely herniated out of her larynx, despite it being 15. So we actually put the tube in, took the cuff down. We still were ventilating. Don't pull these tubes. Don't pull any tube. If you can get some type of CO2 and you're oxygenating and you're reasonably getting minute ventilation, don't pull the tube. So we didn't. Just drop the cuff, push it in further. And with the glide scope, we could all see it really go. Because, you know, this kid's view was a little challenging. She had a long neck. And we pushed it in further and then put the cuff up and then fixed our problems. So these cuffs can herniate as well. Remind me to go back and talk about how you can figure out whether or not you're herniating with the cuff before you have hypoxemia. Okay, because there is actually a cool trick to do. I don't do it. I've not been doing a lot of thoracic recently, but I used to do it all the time. Okay, so now we're talking about this tube again. So again, so you're looking at this tube, and the tube, trachea, bronchial, it's left-sided, right? So where to clamp? So you gotta ask yourself, what am I trying to ventilate? The lung I'm trying to ventilate, do you think it's a good idea to clamp that side of the lung, right? No, right? You want to ventilate the lung. If you clamp it, you can't ventilate. So the side I clamp is the side that I'm not trying to ventilate. So I don't know how you're going to remember this or how you're going to think of this. Just think of, just take your time watching videos and looking at these pictures and stuff. Because you're going to get questions on the test that are going to be like, just like this. This is the left side of double lumen tube. Assuming it's in the left side, we're not going to can't guess it. And if you had one of these pictures, well, which side are you ventilating, right? And you'll also notice too, something's wrong with that left picture too. So it's putting in play all these four pieces. So left-sided double lumen tube. Left side double lumen tube. Blue is the bronchial side, and then clear is going to be the tracheal side. So if I clamp blue, I'm not going to be ventilating the bronchial side, right? If I clamp the tracheal side, I won't be ventilating which side? Well, it depends. Because if I'm clamping both, but I don't have the cuff up on the bronchial side, what changes? So let's do this. Let's say, what's easier, the board or just holding this? It's hard, right? So we have something. Is there a syringe in that box?
Yes.
You want to give me the syringe?
It might be in that box right in front of you.
Oh, this box. Perfect. Okay. So maybe we'll just do a couple scenarios and this might start to click. So I put the tube in, it goes into the left lumen. I inflate the tracheal cuff, but, to like 20 centimeters or whatever. It never really fully turns into a balloon. And I actually really think that this could be, I think this cuff is actually that. This is a lot of air. We never need that much air. Okay, so right now, if I just want to ventilate this patient before surgery starts, I don't need to do anything with the bronchial cuff. Like, there's no reason to put pressure on the actual membrane of the tissue in the bronchus unless you absolutely need to drop that lung. So I do absolutely nothing with that blue cuff. And also, before I put this tube in, I make sure all the air is actually out of the cuff too. So right now, I'm just going to ventilate through both sides because, again, this whole lumen is split into two chambers. So why put all that pressure into just the tracheal side? I could just do this, right? I could actually clamp this. If I clamp this right now, I clamp the bronchial, and I just ventilate it. I have to close all these air ports. If I just ventilate it right now through this tracheal side, the clear side, I'm only going to be sending air out of this little hole here. If that's above the carina and this cuff is down, I'll ventilate the right and left bronchus, right? Now, if I said, perfect, oh yeah, don't put the bronchial cuff up, and you hear me tell you, hey, look, let's just ventilate them, not put the bronchial cuff up, let's just ventilate both lungs, and you didn't have this piece, and you said, no, sure, no problem, and you hooked up the tracheal because that's what you're most used to, or are you going to be ventilating them? I want the same outcome, except if you're new and you don't know how to use this, if you start ventilating through the trachea, all the air is going to come right out of the bronchial tube, because this is open. So the air comes out of here, out of the trachea, goes down the right MAINSTEM, but it's going to go to the area of least resistance. You have a thoracic cage sitting on top of your lungs. So yeah, it might ventilate some tissue, but it's going to go right through and back out this bronchial tube, come right out of here. Because again, you're hooking the circuit up to here, this is open. So you could do it. What could you do if you lost this piece? How could you ventilate through just the tracheal hole, but still ventilate both lungs? Yeah. The clamp. Is that in the box up there? Clamp, clamp, clamp. So one of the ways that I can ventilate through, if I want to ventilate both lungs, but I lost the 2-to-1 piece, I can just clamp the bronchial like that, and now air won't come out of this tube because this tube is included from up here. I'll ventilate through this port because I only have this hooked up to my circuit. Are you guys getting this, or is this like good to talk about? I'm ventilating through the tracheal port here. I'm ventilating both lungs. The other option you could do is if you don't have a clamp, and well, actually no, that's the only option you can do. That's the only option you can do. If you were to ventilate through here, like this, what's going to happen? Same situation, but now it's a different bronchial side. What am I ventilating? Left lung, right lung, both lungs, no lungs. Which side am I ventilating through? I'm in the left, I'm the bronchial, so I'm on the left side, I'm ventilating. Where's the air going to? The left, but the cuff's not up. So it's also coming out of the left side, and it's ventilating into the right side, but it's also coming out of this open tracheal port. See? If I were to inflate this bronchial, if I were to inflate the bronchial, it's inflated. What am I ventilating? Only left. I have successfully isolated the right lung. I'm only ventilating the left. But now I make it more complicated. You found the 2-to-1 piece. I put the 2-to-1 piece on. What am I ventilating? 2 cuffs are up, 2-to-1 piece is on. What? Both. I'm ventilating both. I haven't isolated anything. I'm losing all my stuff. What am I ventilating now? Tracheal port's clamped. Just the left. Do I still have air inside the right side lung? How do I get the air out? How do I deflate the right lung? I'm ventilating the left. Ventilating the left. How do I get the air out of the right? Gotta take the little valve or where this little plug is off. Now I'm still only ventilating the left, but now air can come from the right side through that tracheal port and out to this open air port to atmosphere. Okay? If I had kept this closed, they would have been like, hey, if this lung's still up, you'd probably look on their screen if it's a video, you can see it's not moving with your ventilation, but there's tons of air in there. It's because you left your port closed. So there's so many ways we can ask questions with the stuff. So if you guys want to look at it again afterwards, I highly recommend you look at it again. Okay, this is a picture that helps again with the different views and different things being clamped. So these are just preoperative testing and stuff. What might concern you with these testings, PFTs, ABGs, people's reserve if they're doing physical activity and stuff. That's also, we usually ask them, can you climb 2 flights of stairs, but you can actually do more definitive testing. So you have to know these numbers. So I changed some of these PowerPoints. It's updated now. This morning I was adding more and more to it. You know, some of this PowerPoint is actually, it's a great PowerPoint. Most of it actually comes from Marianne and stuff. She let me use her PowerPoint a couple years ago. And just some of the newer research that's coming out is really the goal of how much FiO2 you're going to give is just enough to maintain a SAT of 92. And that's like in that sinusoidal type of curve when you think of the actual hemoglobin curve. How much bang do you get for your money as far as like fully saturating your hemoglobin? Hemoglobin is like the majority of your delivery comes from hemoglobin. Like who cares what the PO2 is? The PO2 is important for as far as the passage of O2 to the hemoglobin, not the hemoglobin, in a sense that like concentration gradient. But really your bang for your buck is going to be hemoglobin. So you get the most bang for your buck pretty much at, what number is this down here? I think this is how it goes. You have your curve, you have your y-axis, which is SAT, and here's your PO2. Yeah, I think it's 60. So pretty much at 60, you're guaranteed to get a saturation of what? 9. Yeah. So basically, you mostly maximize the person's oxygen delivery abilities with a SAT of 90. So if we maintain SATs of 90, we're pretty comfortable knowing that we're getting enough oxygen where we're going. So it might just be a factor of getting the cardiac output to adjust, but a SAT of 90 to 92% is pretty reasonable. So if they don't need 100%, don't give them 100% FiO2. The thought is like if you give 100% FiO2, you have more of a threshold for when things go wrong because that's your whole FRC, right? That's your, what's the two volumes that make up the FRC? Capacities are always two volumes. And yeah, right. And that's just your reservoir to take from. So you can still oxygenate without ventilating for so many minutes depending on the person. So in reality, run your FiO2 at a reasonable level that allows your oxygen saturation to be above 90 to 92. 92 I think is a better number to go with. Bleomycin though, this will be like a test question. You can develop actual fibrosis of the lungs after being on this chemo agent because of free radicals in the presence of high FiO2. So you don't want to exceed 30%. That's really hard in these cases. Previously, the reason why they also thought 100% was good because they thought that it would actually cause vasodilation in the actual ventilated lung, which is good. Obviously, vasodilating is a good thing because you want blood flow. Blood flow would mean that more blood's going to the ventilated lung versus the unventilated lung. But again, I think the toxicity, it's known the toxicity from high FiO2 is not good. You also get absorption atotasis as well. So if a lung gets 100% FiO2 but then collapses because all of it gets absorbed, that causes its own trauma and inflammation because the alveoli is closing. If it all there's no nitrogen stenting it open, and then when it goes to open up again and then close again, that's a lot of trauma that causes oxidative stress. And that's well recognized with acute lung injury, ARDS. In our last PowerPoint, we'll talk about something from all this. So tidal volume goal is actually small. We used to just bang in 10 cc's per kilogram into the one lung during one lung ventilation. That gives you the ventilation that you're looking for if you're going to have some HPV going on in the down lung. And in the good lung, hopefully all that blood gets rerouted to the good lung. Well, you gotta catch up with the actual minute ventilation, right? You got a lot more blood going to the lung that you're ventilating now. But achieving it with high tidal volumes is shown to cause trauma to that lung and stress. So you can achieve that with lower tidal volumes, and this is mostly in animal studies that show this, and it causes less free radicals, less stress. The catch is if you're going to run low tidal volumes like 4 to 6 or maybe just shoot for 6, you want to make sure you run PEEP at the same time. This doesn't work without PEEP. So there might be patients that you don't want to have PEEP on. And then the question of end-tidal CO2 is the next slide. It might be actually good to have a permissive amount of hypercapnia. Low tidal volumes is also good because that means there's going to be smaller movement of the lung fields, which might be helpful if you're operating on, if you're not dropping a lung and you're operating on that side. That could be beneficial as well. Maybe you don't have to drop the lung at all. You're also, as you're ventilating the dependent lung, that's still moving the thoracic cage, which could also interfere with the surgery on the non-dependent side if you're doing large tidal volumes. So hypercapnia is probably okay. The only people we worry about is the people who wouldn't respond well to hypercapnia. So hypercapnia in the systemic system causes what? And in the pulmonary vasculature, it causes what? Vasoconstriction. If I vasoconstrict my pulmonary vasculature, what do I do to the PVR? If I increase my PVR, what does the right side of heart have to do? It strains it, right? It makes the right side of heart have to overcome the hypertension in the pulmonary vasculature. So someone that has a weak or poor functioning right side of heart, you'd be looking in the echoes for these kind of people and determining what you're comfortable with because you're looking at hypercapnia, right? Insufflation of the lung, it's a closed system, or closed surgery. We're not ventilating well because we're doing small tidal volumes, high rates. We're worried about possibly dynamic auto peeping. So you're sort of like, these are all things that are going through your head. This patient might not tolerate it. But in the systemic system, you're causing some vasodilation or causing some cardio depression. So these sometimes might need some inotrope support. You might tolerate it. You have to have that discussion with whoever you're working with. But with people with the bad pulmonary hypertension and right lungs, right hearts, they're probably not the best people to tolerate like hypercapnia in the 50s or 60s. So you get hypoxic, so your sats are dropping. The first thing you do is you go to 2 lungs, you go to 100%. You tell them ahead of time because, look, you got to let them know they're in the field operating and cutting things. Afterwards, you go and look. What can you do for hypoxia? You're just not getting good stat numbers despite all the things that you're doing to help this patient. Let's say we're assuming you're under 1 lung ventilation. So one of the things you can do is on the double lumen tube, you can, I don't have one. I was actually going to take one from work yesterday. Mapleson circuits, we've all had those in the anesthesia class, right? You can stick a Mapleson circuit. So what I would do is I would pop this off. Both cuffs are up. All I care about is I'm ventilating the left side. But my operative side is not helping us when it comes to ventilation. It's still getting a percentage of cardiac output. Despite you helping us, we're still going to have shunting. I'm struggling in this case. I'm trying to oxygenate this patient. I don't care if they fix the patient or not, they're going to have problems, right? They're not going to oxygenate and cause ischemia. So what I can do is instead of keeping this closed, I can put on the Mapleson circuit. We have Jackson Reese in pediatrics, and having a pediatric bag actually works really well because it's a small bag that you can see physical changes when there's air in it. I'll tell you why. It doesn't have to do with CPAPing, but we can hook the bag up to here, and this is the kind of the ghetto way to do it. There are devices that do this, and you can actually measure out what your CPAP is. But you can put the Mapleson circuit or the Jackson Reef up to here. It fits just like it went onto the endotracheal tube. It's the same diameter. It clamps onto here. You're going to put a couple liters of oxygen to it, and those circuits actually have an APL valve. It says close, go this way, and then you assume if you go the opposite way, it opens. You would close your valve off slightly until the bag fills up with oxygen and causes a little bit of pressure, and that pressure is then going to be parallel to what the pressure is in the operative lung. And you just add a little bit of CPAP to the lung. You would still probably leave open, you probably would close this because then it would override its pressure through the APL valve, and you tell the surgeon you're adding a little bit of CPAP. That's one possible way to fix this situation. The Jackson Reefs actually are also helpful when you're assessing for herniation. So if you had the Jackson Reef, because that's a possible intervention for hypoxia, and you were worried about herniation, like let's just assume we're ventilating this side. So if we're ventilating the right side, we're operating on the left side, we have to close the side that we're ventilating through, right? And we want to open the side that we're not ventilating through. Well, one of the things that you could do is you could put the Jackson Reef onto here. It has a exhalation side to it. You could close this, and as you're ventilating, air is only going to the right side, the left lung is down, but if this were to herniate and then you started ventilating around the herniation here, you would actually start to see air going into the Mapleson circuit, the little Jackson Reef. That green bag, we all know what I'm talking about, Mapleson circuit, starts to inflate with every ventilation. It's inflating. You now know ahead of time before you have a true problem that you're starting to get some type of leakage into the side that's supposed to be down. So I think the Jackson Reefs are really helpful for more than one reason. Oh, clamping the PA. So things aren't working. No matter what you're doing, you're hypoxic, you're on 100% 5.2, you're just not oxygenating the patient. The surgeon can completely eliminate the shunt that's going on in the actual operative side by clamping the blood that's going to it. So it physically can't go to a lung that has no ventilation. Oh, here, this is actually a picture. I forgot this here. So here's an opportunity where you can actually, this one is, this one has like a PEEP type of device where you can kind of see what you're giving. So that's actually, fancy stuff. That's great. I've never seen one. Positioning. The non-dependent arm goes on a holder. So you got to be careful with nerve injuries. You might want to do an auxiliary roll if they're on their side. You want to check their eyes and ears because all this tubing's coming out right here. It's all in their face. Their arm is on like a type of Lugic device that's right by their face too. If they were to wake up early, they can hit their heads right on the arm device. So you might not want to extubate them early. They put the bed in a flex position, so it cranks them like this, so that it really opens up their thoracic cage. Fluids are really important. If you give too much fluids, it's definitely a contributing factor for post-op mortality, morbidity, and for lung injury. So you run them on the drier side. You don't accommodate for fluid deficit from like the thoracic cage being open. And you might tolerate putting people on phenylephrine drips longer. Like, we're not going to give fluid, leave them on the phenyl drip until they stop vasodilating. Urine output's reasonable. Let's just send them to the unit with a little neo going. Volatiles, you start thinking of what affects HPV, and volatiles are shown that only in like super therapeutic levels can inhibit HPV, so they're safe to give. And the trade-off being is that they can actually dilate. So we like the dilation side of it, the bronchodilation. HPV, we've talked about this in depth, but basically it's in the small arterial vascular beds, and it responds to the actual oxygen levels in the alveolar space. And if it senses that, it goes through like a mechanism with like potassium channels, which then are closed, and then you reach threshold and you release like L-type calcium channels that then cause calcium release, which then causes vasoconstriction, the smooth muscle, which then causes the constriction. Just talked about this. Nitrous does significantly inhibit HPV, so don't run nitrous on these patients. It's also probably not good too if they have a pneumo afterwards. Once they close the chest, that's why they always have chest tubes. You can add to it, and just not a good idea to run nitrous. These are all different things that can inhibit HPVs directly, so anything that vasodilates and you give it intravenously can do it. Other factors that can increase pulmonary artery pressure, thereby inhibiting HPV, would be fluid overload, hypothermia. So these are sometimes things that could affect ventilation perfusion, I guess is probably a better way to look at it. This is another graph of drugs and stuff that can affect it. The graph on the right is just a picture of HPV, the mechanism. So what would be the clinical difference between giving nitric oxide via inhalation versus intravenous route on HPV and ventilation perfusion mismatching if you're on a one lung ventilated patient? So if I give nitric oxide IV, will it make my VQ mismatching worse or better? If I vasodilate an area that wants to be vasoconstricted, do I inhibit HPV or do I maximize it? You would inhibit it, and that's not good. We like HPV. HPV is a good thing. It's a natural way of saying, dude, don't come here. We don't have oxygen. Go somewhere else. There's no food. But if they come for food and there's no food, they return back home hungry and grumpy, right? We don't want that. We don't want to dilute the good blood. We want to dilute the nice people. If I gave nitric oxide inhalation, well, obviously I'd be giving them through the good lung, the lung that's up. It's not going to go to the bad lung because that's clamped. If I cause bronchodilation in the good lung, I'm increasing my passageways of ventilation, therefore I'm ventilating more, and I'm also possibly increasing blood flow, which means that I'm promoting more blood flow and more ventilation to an area that is actually partaking in gas exchange. So that's a good thing. It would improve your VQ mismatching. So intraoperatively, you can lose a lot of blood, tons of structures there, tons of vessels. We already know with the mediastinum what's down there. Tamponad's always a risk. They could instrument with the robot easily, so be prepared, looking for narrowing pulse pressures, hypotension, tachycardia. You could definitely have lots of risks for arrhythmias during these cases at all times. Ischemia MIs, you're not sleeping under anesthesia, you're really going through a marathon. At the end of some of these cases, they'll test the actual, if they took a lobe off, the rest of the lung on the right side is still there. They may have only taken one partial lobe or full lobe off. They don't take the whole lung off normally. But no matter what they do, they'll close it, and you want to just make sure it doesn't leak. So they might put water in there to see if it leaks and bubbles. So at those times, they want you to give a Valsalva maneuver and hold pressure between 30 to 40. One of the things I noticed in some of the literature is that when you do reinflate the down lung, go slow and don't use 100% FiO2. The more FiO2, you're just contributing to those free radicals. So I would try and use air in that case. And guess what? Assuming this is a Mapleton circuit, that we had available for the hypoxia, or we had available for like watching for like the bronchial cuff coming out and being displaced, as we see in inflating. It also allows you to not stop ventilating them, to unclamp, hook up the pieces, and then to ventilate them like both at the same time, which is not good because again, all the downtime, the cyclic allocasis of airways opening and closing causes free radicals, causes stress. So what would happen is you would still be ventilating whichever lung you want, and then the side that they want to just slowly open to test some stump pressures, use your MAINSTEM circuit. Put it on. In this case, you probably would have to put on oxygen because there's probably not a lot of ports available, but you could go find a tank of air. I mean, go for it. And you could just slowly close your pop off, put enough flow in there so the bag starts to inflate, adjust your pop off like you would for masking people so you're not giving too much pressure, and slowly start to inflate the lungs. They'll be like, come on, let's go, let's go, let's go. They don't care what happens to patients afterwards. They're just operating. Oh, I'm going. Give me a second, I'm going. And then close your pop off and hold pressure. Hopefully you have a MAINSTEM circuit that has an actual pressure gauge on there. You can find ones that can also go in between, but you're going to hold pressure maybe at 40, whatever it is, and then it eliminates having to turn a ventilator off in order to do this. Because again, you can't just turn the ventilator at vital capacity on machine hit vital capacity and think you're going to just open the lungs up that fast. You have to slowly bring the lung back up before you can apply the pressure at 40 or 30, whatever you want. All right, post-operative. If you can extubate, you should, but you have to think about the person's DLCO, their PFTs, their cardiac exam on their echo, and you have to consider if these people are reasonable to extubate. How much lung do they lose? How are they oxygenating? Maybe before you extubate them, you put them on lower FiO2 requirements. What are they going to do on 30 to 40%? Because they're definitely not getting 100% when you extubate them. But we pull the tubes to 100%. Are we pulling? Is pulling the tube to 100% a good idea always? It's questionable. Absorption alactasis, right? Hyperoxia. Like, should we just have them on 100% extubation? But most people are never comfortable keeping them at 70 or 80 or what have you because they want that extra bucket of oxygen ready and available if something goes wrong. If they don't look extubatable and you're sending off ABGs, you're checking like their AA gradings, you're checking what their numbers look like, their pH, are they off pressors, like all these things, and their tidal volumes, like all these different exams, you might have to take the double lumen out, put a single lumen in. If you have to do that, you should exchange it over a tube. So we have a couple different devices that we can do that with. So one of those devices, these are really Yale tubes. I don't like these. It's not good when you can't open it. This is a bougie. These are flimsy bougies. The blue ones at St. Ray's are really nice. You guys have blue ones or gold ones at Hartford? Blue. So bougie, this is really too flimsy. These are terrible. But the blue ones are much more. So bougie normally is great for you can't get the tube in. You keep trying to look at all tube. It's too interior. You're struggling. It's probably because you're just not good at doing the DL and stuff. But you got like a grade 2.5. That's when you're like, instead of just being like, like, and you're like, okay, move over. You're like, I'm gonna bougie it. Just say it. Like, I'm gonna bougie it. Know where your bougie is. Bougie's right here. Grab a bougie. Like, I'm gonna bougie it. We're good. Take your tube out. You DL. You look at your cords, and you put bougie pointing anterior because you're gonna feel the cartilaginous rings. You go in. You slip that baby in. It's gonna go right in. Oh, it's a little interior. You bend your bougie. This is not a good bougie. But you bend your bougie. The blue one's full. You bend it. Oh, I gotta go more interior. You get it up there. It pops in. Push it past the cords. Feel the rings. If you put this on your fingers here, this is what you'll feel. You'll feel those little bumps. And feel it afterwards. Come down here and feel this. You know you're in the trachea. Grade 4 view. You don't even see the epiglottis. The bougie. I don't see it, but I'm bougie it. Grab the glide silver. You're still not ventilating right now, and you have a couple seconds. Try and put this in real quick. So again, you have no view. You know the cords are somewhere under that tongue. You know, there's a tongue, little groove, which is called the vallecula, and then you have the epiglottis. You know somewhere kind of down here, you have the cords up in here, right? So you kind of slip it in there. You get into some kind of hole, it's either esophagus or trachea, it can't be anything else. If it's pointing upward, you're going to feel cartilaginous rings. Esophagus doesn't have that. So then you know you're in. You slide your endotracheal tube over without the stylet. So reverse is true here. So double lumen tube. I have an exchange catheter, which is a little bit nicer. But double lumen tube, I'll go down Which one would I go down? I think I'd go down the trachea. So you go down, the trachea would be the best. See, this might not work. Okay, so see, we're figuring this out right now. You get, if the bougie doesn't fit, you get an exchange catheter. This is a exchange catheter. Has a little device that hooks onto the top so you can actually ventilate through it. This should. This side's a little bit easier to go through. Go in. You can watch this under the video scope too. You could go down the other port, I don't think it really matters. And then you pull your tube out. Comes out of the airway, being careful to leave the tube. Tube's hopefully not past the carina, it's very stimulating in the carina. So it's a little bit above the carina. Tube's just sticking in the airway. If you're ever worried about edema, post-operative edema, but you think you can extubate the patient, stick this in. Tape it right to their cheek. Here's your airway. You can passively oxygenate through here, a little bit of pressure, and when their airway closes, because that little bit of edema now has a place to go because the tube's not sending it open, and you can't see their airway anymore because everything above it's also swollen, you could pass a tube over this and re-intubate them. This is a potential, right? Or you just want to put a tube in, you're not going to mess with it, and read the tube. What do you have it? Take the tube, whatever's appropriate for the patient to wake up on, stick your tube on. Same with the bougie. Stick it up, stick it up, stick it up. And once it gets down to the cords, you're going to feel a little bit of resistance. Don't jam it in. Twist. Twist the tube. It usually pops up and over the cartilaginous, what is it called? The retinoids and the corniculate. Now your tube's in, take it out. Still listen like you normally would to make sure that you're definitely in. They get shoulder pains from the insufflation and stuff and positioning, so Toradol is the best thing. Epidural anesthesia is an awesome thing. Tori has a lecture talking about her case, which I'll put up today for Friday. She also has her esophagectomy lecture there, but she talks about the regional stuff. Plain old thoracic epidural works wonders. If they're in a lot of pain, they're not going to take deep breaths. They're going to develop more atelectasis. They're already coming out deconditioned, so you want to make sure that they're really breathing, spirometry, you're really on top of them, moving and ambulating, so pain control is important. Flow chart. So you could have immediately, hemorrhage could also then start at an anastomotic site. So you just have to watch for the chest tube. You know, we usually aren't actually like in the remaining lung tissue. It's outside it that we're removing. We're taking a lobe and cutting it, closing it. But you could theoretically get inside that space, that cavity, the thoracic space. You could have bleeding from that site, like an artery wasn't really like sutured off or bovied right, and now you get bleeding into the pleural space that comes out of the tube. So that's one of the places you can check. If you get really bad PVR, 10 to 20% of people actually have a patent foramen. You can make that patent foramen more patent. So blood doesn't want to go through the right heart to the lungs because there's so much resistance. It goes to the left heart. It goes right to the left atrium. It says, this is easy. Why work harder? And then you have a shunt, right? You have poor blood, poorly oxygenated blood going to the left side of the heart, mixing with the oxygenated blood. Injuries are pretty straightforward. Cardiac arrhythmias are very common. Other complications. Okay, so PPPE, post-pneumonectomy pulmonary edema, is a major problem that we talk about the most when it comes to fluid overload. It's somewhere in between like ALI and ARDS. It's not as bad as ARDS, but it's like worse than ALI. And basically the way that you measure it, or kind of an idea of like how bad your alveolar capillary membrane is comparing what we were talking about, that's what I was talking about earlier, which is the difference between what you have in your blood, your PaO2, and what you're delivering. And the difference between those two is, as it grows smaller, it means you have more of an injury. It never gives you really basically what a value would be for diagnosing PPPE, but you just can see that you're probably between that like 200 to 300. So it's not good. I think that's how you take from it. You can call it whatever name you want. It's not good. you have a risk for acute lung injury after all thoracic anesthesia, that you're doing all this stuff, you're messing with the lungs. And ALI is not good, right guys? You can get ALI from blood transfusions doing a back case. Bad for your lungs, increases your morbidity and mortality significantly. Sorry for the misspelling on the slides. So it is important. It's almost 3 times more likely, or 2.5 times more likely with pneumonectomies, because you're taking out the whole lung. So what are the risk factors for this, any type of lung injury, and in general for PPPE? Well, here you go. These are all your risk factors, procedural stuff, patient-related reasons and stuff. We can cause lung injury from the good lung, and we can have lung injury from the bad lung. And then overall, what's probably going on in the background is, immune system, stress, oxidation, cytokines.